Hello, my name is Laura Van Brocklin, and I'm a nurse practitioner that works in electrophysiology, or EP, at Denver Health in Denver, Colorado. Today, we are going to be working on the recognition of AFib. We're going to explore recommended and advanced screening tools through a whiteboard animation. Our learning objective today will be to identify patients at risk for nonvalvular AFib through recommended and advanced screening tools. Let's take a moment to go through the prevalence of atrial fibrillation of AFib. AFib prevalence is high. There's a lifetime risk for AFib of 15 to 40%. This risk is continuing to grow, and it's estimated that the U.S. prevalence in 2010 was 5.2 million, and then it is projected to be in 2030 12.1 million. Estimated global prevalence in 2020 was 50 million, and by 2050, the estimated prevalence is to be 66 million people affected by AFib. And AFib is associated with significant health consequences, including it causes about 20 to 30% of ischemic strokes. It increases the risk of heart failure by 5-fold and increases the risk of death by 1.5 to 3.5-fold. The most important part to remember for our patients is that it actually affects more than 60% of patients' quality of life. There are some solid steps that we can follow to improve the outcomes for people with AFib. The pillars of AFib management are for all patients to receive stroke risk reduction, optimization of modifiable risk factors, and symptom management of AFib. It is important to remember that the basis for this is shared decision-making and treating the risk factors of behavioral changes. Things that we can actually change are exercise, well-controlled diabetes, tobacco use, alcohol use, and improving sleep patterns, and hopefully obesity. People can't take these steps if they don't know they have AFib. 10 to 23% of people with AFib are actually not diagnosed. 10 to 40% of patients with AFib are asymptomatic. What are the criteria for AFib diagnosis? Things that we would see or notice on an EKG would be irregular R to R intervals. They don't line up. They are not regular. You can get out your calipers, and they're all over the place. Absence of distinct P waves. This is also something that you can kind of try to convince yourself when you're looking at EKGs. Am I seeing a P wave or not? And if I am, what are they doing? Irregular atrial activity. This is where you're kind of seeing the P waves, but they're not in a regular order, and what we call fibrillatory waves. So when they're kind of just all over the place and going fast. Who should be tested for AFib? This can be a variety of different people that come into your office, and these symptoms are vague, so just be aware that people often present with these vague symptoms of palpitations, dyspnea, fatigue, chest tightness or pain, poor effort tolerance, dizziness, syncope, disordered sleep. Other people that should be looked at who are kind of asymptomatic would be those who are visiting their healthcare provider and people who are at high risk for AFib. The USPSTF does encourage clinicians to use their clinical judgment regarding whether and how to screen. This does leave this a little ambiguous for us who like to follow the guidelines specifically, but it does leave us the opportunity to use our clinical judgment on who is best to screen for AFib. Tools for identifying and confirming atrial fibrillation. Here we're able to review some of the tools that we can use to help us identify atrial fibrillation. So, pulse measurement. This is something that we're able to use that is not expensive and even can be done in any clinic setting or at home. We also have the EKG or electrocardiogram. Monitors that we use as clinicians involve cardiac, event monitors, or Holter monitors. Lastly, in the clinical setting, we can use a long-term implantable cardiac monitor. And finally, at home, some of our patients have already started or will ask about personal wearable devices. Identify the true statement regarding pulse measurement for AFib assessment. A, it is helpful in screening for irregular or fast rates. B, it is not useful for AFib assessment. C, it can be used for self-diagnosis. D, it cannot be used for self-monitoring. Pulse measurement. This is a simple and helpful tool in screening for irregular or fast rates. This cannot in itself diagnose AFib, so there is no EKG tracing to confirm. It's subjective to sensitivity of the device and to the person checking the pulse. Any concerns with pulse monitoring should be followed up or confirmed with an EKG tracing or a monitor. It can be helpful in self-monitoring following an AFib diagnosis to be able to see if they are in an irregular rate or if their rate is going fast. I am most likely to use the pulse measurement in my current practice when I have somebody who is unable to have a wearable device or somebody who is already diagnosed with AFib. Oftentimes in EP, the patient has already been referred because of the concern of an irregular heartbeat. So in the primary care setting, it's likely to be used in a way to figure out if the patient feels like they're having irregular beats when having symptoms. Identify the true statement regarding pulse measurement for AFib assessment. A, it is helpful in screening for irregular or fast rates. B, it is not useful for AFib assessment. C, it can be used for self-diagnosis. D, it cannot be used for self-monitoring. B, it is not useful for AFib assessment. Pulse measurement can be useful because it helps us figure out if a rate is regular or irregular, fast or slow. C, it can be used for self-diagnosis. Unfortunately, none of our tools are capable of self-diagnosing AFib. There is the requirement for a clinician to review all ECGs. D, it cannot be used for self-monitoring following AFib diagnosis. Pulse measurement is very useful in self-monitoring to see if a patient is in a rapid ventricular rhythm response. So this, in and of itself, the question is incorrect. Electrocardiogram, or ECG. A 12-lead ECG is the preferred method of diagnosis. It is our gold standard and a Class 1 recommendation for diagnosis of AFib. With 12 leads, atrial fibrillation can be differentiated from other atrial arrhythmias or ventricular arrhythmias like PVCs. Limitations. It's a moment in time. Our patients can go in and out of atrial fibrillation, as many of you know, and it can be difficult to identify paroxysmal atrial fibrillation. When I am most likely to use this? Well, in EP, we get an EKG on almost every patient that walks through the door. Obviously, in primary care, that is not effective use of monitoring and evaluation of every patient to have an EKG. But this is what you would use if you have concern or screening for a patient that has an irregular heart rhythm on auscultation or listening to them, if their pulse ox is jumping all over the place when they're getting their vital signs, or if this is somebody who happens to be in clinic, like we said, with those distinct or vague symptoms of AFib. Cardiac monitors. They're worn over a period of days, anywhere from 1 to 30 days. Holter monitors are anywhere from 24 hours to 2 weeks. These capture everything that happens in that time frame and is able to give us percentage and quantification of how much or how little patients have regular or irregular heart rhythms. Event monitors. Those can also happen over the same duration from 1 to 30 days, and typically those monitors show us when there is something out of parameters or if the patient has symptoms. This assists with finding out if the patient's symptoms are actually correlated with irregular heart rhythm. The cardiac monitors are a Class 1 recommendation by current guidelines. So I would most likely use this testing in any patient that I suspect of atrial fibrillation or has diagnosed AFib. It can give us a burden of AFib, as well as help us determine if there are other arrhythmias that are occurring for this patient. It also is super helpful in telling us, hey, does our patient have symptoms with AFib, or do they have symptoms when they have heartburn and have nothing to do with AFib or anxiety or anything like that? This helps us kind of narrow down our patient's symptoms, which can be really empowering for our patients. An implantable cardiac device. These are often called loop recorders. There's a variety of different monitors on the market. This is continual monitoring for 3 to 5 years within set parameters. So when the device is inserted in a quick procedure, less than 15 minutes, they're able to then have this device that will track with them over a period of time. Patients can also track their symptoms, which can assist in correlating their symptoms to arrhythmia. It can involve remote monitoring, so they're able to not come in for visits, and they're able to also call in when they have symptoms and get live results and in that moment. Long-term monitoring with a loop recorder is the highest sensitivity for AFib detection. There are some limitations for some patients. It can be costly if you do not have insurance. You will also need to have accessibility to the clinic for reports. And also I've found with my patients in a safety net hospital, inconsistent housing can be difficult for the remote tracking as well. They can still come into clinic for their checks, but it just doesn't help us as quickly to identify AFib. When am I most likely to use these? An implantable cardiac device is indicated for any patient who's had an ischemic stroke to make sure that this stroke did not come from AFib. Also, I use it in patients who have had syncope or fallen down to look for arrhythmias that include AFib, but can also include other diagnoses. Also, if you've had a patient that really can't tolerate wearing an event monitor or a Holter monitor just because the stickies or whatever irritate their skin, it is a consideration. Definitely a little more invasive, but once you are able to get the results, then you have an answer to what might be causing their symptoms. Pacemakers, defibrillators, and their assistance in identifying AFib. Pacemakers are great for identifying AFib because you have a lead right in the atria. Dual leads involving an atrial lead are more specific in identifying atrial fibrillation. Ventricular leads can give indications of atrial arrhythmia, but they are not right in the atria for us to know exactly what the electrical activity is doing up there. Remote monitoring can help with timely identification. In practice, we use this all of the time. We get a remote monitor. It tells us that there's been a fast rhythm. We take a peek at it. It's irregular. We're able to call that patient in almost immediately to be able to get them in and get them on oral anticoagulation if indicated, and also get them under good rate control. Interrogation on a regular basis for atrial high rate episodes is a class 1 recommendation of the European guidelines. The US guidelines really hone in on the ability to get patients on oral anticoagulation as soon as possible. In EP, it's easy for me to use this as a tool to identify AFib. In primary care or in other settings, it might not be as readily available to interrogate a device. But in emergency room setting or in urgent care, you can always call to get a rep to come to your clinic and check out a patient's device. Primary care, hopefully if they have a device in, they already have an EP provider, but if not, it's a perfect opportunity to get them over to cardiology or EP and get them settled with somebody who can help them monitor for their device and their arrhythmias. Your patient has received notification of irregular heartbeats from their smartwatch. What is required for AFib diagnosis? A. An accessory lead patch is required for AFib diagnosis. B. Clinician visual confirmation of the ECG readings. C. Continuous monitoring for 4 weeks. D. It cannot be made. Diagnosis requires a 12-lead EKG reading. Personals and/or wearable devices. Handheld EKG devices and smartwatches are all over the place now. Many smartwatches have apps that are readily available on their software to be able to identify irregular heart rhythms. These algorithms to identify irregular heart rhythms can be very accurate and assist us in identifying those who are under-identified for AFib. The limitations are definitely the cost to a patient, and you should definitely have a healthcare professional interpret and review the EKG tracings. This again is a recommendation by the most current guidelines for 2023. I am most likely to use the information from personal and wearable devices for patients who already have them. I typically do not find myself recommending these to patients, mostly because of the cost of these devices for my patients. I do work in a low income setting, so in other settings it might be more appropriate to recommend this for patients as a tool for identification or as a tool for monitoring prevalence of AFib once they've been diagnosed. The guidelines recommend at a level 1 recommendation that any reading or tracing of possible AFib be brought to a clinician for confirmation of AFib diagnosis. Any and all approaches to detection of the arrhythmia should be used by us all so that we are sure to identify and help treat these patients for their symptoms, optimize their risk factors, and then also make sure that those who need it are on oral anticoagulation. Your patient has received notification of irregular heartbeats from their smartwatch. What is required for AFib diagnosis? A. An accessory lead patch is required for AFib diagnosis. B. Clinician visual confirmation of the ECG readings. C. Continuous monitoring for 4 weeks. D. It cannot be made. Diagnosis requires a 12-lead EKG reading. A. This is not the tool required to diagnose AFib. C. Continuous monitoring for 4 weeks. This is not required for diagnosis of AFib. D. It cannot be made. Diagnosis requires a 12-lead EKG reading. We're able to use a variety of different tools to diagnose AFib as long as the clinician, answer B, is able to visually confirm that the ECG readings give us an AFib irregular rhythm. So some clinical pearls for you guys to take home in diagnosing atrial fibrillation. Utilize any and all tools and data available for screening. If you're concerned about whether a device or a reading is not clear, definitely consider long-term monitoring with a cardiac monitor or with a loop recorder for high-risk patients, symptomatic patients, or previous stroke. Also remember, there is the need for professional review of suspicious EGMs or ECG tracings.